For many patients in Western countries, particularly the United States, a standard medical procedure carries a crushing financial weight. A single hospital stay can generate a cascading list of charges that outpaces an average annual salary. Compare that to India. For the exact same surgical procedures, the final invoice in an Indian hospital often totals a tiny fraction of the Western price. This rising bar chart illustrates the direct result of that price difference. Every year, tens of thousands of international patients fly from Western nations directly to India, making the country a massive hub for global medical tourism. State-of-the-art facilities across India utilize advanced robotic surgical equipment and highly specialized medical teams, matching the technical standards of high-end Western hospitals. If the quality is high enough to attract patients from around the world, the savings cannot be attributed to a lack of technology. The discount is structural. To find out where the money actually goes, we have to tear down a standard medical bill piece by piece. The first major factor driving down the price of care is the physical foundation of the system itself, labor and infrastructure. Healthcare professionals in India, doctors, nurses, and technicians, earn salaries that scale with the regional economy. Because the baseline cost of living is lower, their compensation is lower than that of their Western counterparts, which drives down the cost of human capital. That same regional pricing applies to the physical hospital. Construction materials are cheaper to source, and the daily overhead required to keep the lights on and the facility running costs significantly less. Then we look at the physical materials of care. India is one of the world's largest producers of generic medicines. This split-screen flowchart breaks down the economics. On the left, a branded drug carries heavy financial weights to recoup the initial research, development, and marketing. On the right, a generic alternative is manufactured after original patents expire, bypassing heavy upfront costs. As these generic alternatives flood the domestic market, their sheer volume acts as a deflationary force, dragging the average cost of a patient's pharmacy bill down. The Indian government actively reinforces these low material costs through strict regulations. They place hard price caps on essential medicines and critical medical devices, like stents, to prevent sudden price spikes. By establishing a lower baseline for the facility, the expertise, and the chemical treatments, the starting line for a medical bill in India is a fraction of the Western equivalent. The third major factor is administration and billing. Unlike the US, India does not rely on complex intermediary insurance networks. This tangled web illustrates the standard structure of a Western system. Patients are separated from hospitals by layers of insurance and administrative nodes. Hospitals require armies of administrators simply to negotiate prices with these insurance companies, which rapidly accumulates non-medical costs. In India, the primary financial model is out-of-pocket payment. The patient pays the facility directly. That dissolves the tangled web and zeroes out the administrative bloat. Because patients are paying directly with their own money, hospitals are forced to display straightforward, transparent pricing. That transparency triggers intense market competition among India's massive network of private healthcare providers. Without insurance networks shielding the patient from the true cost of care, hospitals have to aggressively compete on price to attract those direct-paying individuals. Removing the insurance middleman puts the patient in a position of direct oversight. This forces hospitals to use raw market mechanics to suppress markups and remain competitive. Operating at lower costs, however, does not automatically guarantee high quality or universal access for everyone in the country. The Indian system operates on a stark divide. The advanced, highly competitive private sector we just looked at exists alongside a sprawling, government-funded public sector. The public system offers free or extremely low-cost services, but it is notoriously overburdened by the sheer volume of the population. Geographic limitations compound the problem. There is a stark variability in quality and deeply unequal access for populations in rural areas outside major urban hubs. The affordability of Indian healthcare is a specific economic ecosystem, built on regional labor rates, the dominance of generic drugs, and direct payment market competition. India has engineered a system that successfully strips the financial bulk out of medical procedures. Translating that raw affordability into equitable access for all of its citizens remains its ultimate challenge.